Good evening and welcome to our hand and wrist webinar with Dr. Jeff Cole. We will get started momentarily, but first I want to take a moment to explain our format tonight. In a minute, I will introduce Dr. Cole and he will present on our topic. In order to keep background noise down, all participants will be muted throughout the event. If you find that you are unmuted at any point, please just click the microphone on your screen and mute yourself. That would be greatly appreciated. The presentation is being recorded and will be shared on our website, hopefully by Thursday. All that said, we do welcome questions, so please feel free to send your questions to the host via the chat feature on your Zoom toolbar. At the end of Dr. Cole's presentation, we'll open the floor for questions. We have collected a few ahead of the webinar, and we'll start with those, and then we'll go in order of questions received during the event. Again, you can send those in using your chat bar. Usually it's found at the bottom of your Zoom window or on the side. If for some reason we have more questions than time to answer, I will be sure to collect the unanswered questions and follow up with responses from Dr. Cole. Now for a little bit about OrthoSouth. We are a comprehensive orthopedic care practice. We offer orthopedic care across 8 clinic locations and 2 surgery centers in the Mid-South region. We have 5 dedicated hand and wrist specialists that serve patients across all of our clinic locations. And our Briarcrest location is just a little different. We have a dedicated hand center at the Briarcrest Clinic that offers close proximity care coordination between our surgeons and hand therapists. And Dr. Cole will go into a little bit of that in his presentation. Now I would like to introduce Dr. Jeff Cole. Dr. Cole is a board-certified orthopedic surgeon with a certificate of added qualification in hand surgery. He treats problems from the shoulder to the fingertip and routinely makes himself available for urgent care evaluation of acute injuries. Dr. Cole is involved in the Memphis nonprofit scene and previously served as the 2016 president of Carnival Memphis. He also served as chairman of the board in 2017 and remains involved at this time. Away from the office, he enjoys staying active and spending time with his family and friends. He says he is a frustrated golfer, but won't give up the game anytime soon. While a very busy guy, he dedicated some time to putting together what I think you'll find to be a very interesting presentation on common hand and wrist issues. So without further ado, take it away, Dr. Cole.
Thank you, Melissa. Hello, everyone. As Melissa mentioned, I'm one of the 3 hand surgeons at the Briarcrest division of OrthoSouth. First, I want to give thanks to the late Dr. Bill Borland, my mentor, senior partner that brought me into the practice 24 years ago. Dr. Borland was an amazing person, surgeon, family man, led by example. We really, really miss him. One of his greatest legacies was the concept of the hand team. And I'd like to spend more time than I'll have tonight to talk about our hand therapists, but we currently have 3 hand doctors and 3 hand therapists, and we work closely together in the same space. Could spend quite a bit of time talking more about the intricacies there, but the concept of the hand team was really Dr. Borland's, and there are a lot of things that go on in the treatment of a hand patient between the doctors and the therapists. Teamwork, access, frequent communication are keys that drive excellent patient outcomes. A couple of things to clarify when someone says hand surgeon. Usually we're talking about someone with additional specialty training associated with the wrist, the hand, and the elbow, the upper extremity, we'll frequently call it. That extra training is called a fellowship. Even though we call ourselves hand surgeons, more than 50% of our work is non-operative. There are lots of problems that we can fix without surgery. So more than half the time, speaking of ourselves as a quote hand surgeon, we're in the office, hopefully healing lots of things without surgery. Most of you are probably aware that orthopedics has become very subspecialized. Hand surgeons are the specialists for basically all ages. In addition to pediatrics, we're the specialists for sports medicine, arthritis, trauma, and total joints. Compared to a general orthopedist, we're prepared to treat all problems, ranging from the simplest to the highly complex. Friends ask, are there enough patients for you to see just hands? How does that work? And I'll answer, well, there's three of us, so there must be. We feel strongly that if you have a hand problem, you should see a hand physician. In other words, see the right physician right away. In order to make that possible, the three of us at the Briarcrest office, we've arranged our schedules so that we have a physician available at each half-day clinic session throughout the week to see urgent care and walk-in issues. So that's enough of the intro stuff. We'll dig into the webinar. I'm going to cover three things that just seem to come up over and over again, three myths and misconceptions, and then some common hand problems: carpal tunnel syndrome, trigger finger, de Quervain's, ganglion cyst, wrist fractures, arthritis of the fingers and of the thumb. And if I leave something out, we'll have some time at the end to answer some questions. So for the first myth and misinformation, it will move better when the swelling goes down. And sometimes that's just not true. If you look at this patient, deep lacerations to the palm side of the fingers. This patient has no ability to flex those fingers into the palm. And there's really not a need for MRI scanning. There's not a need for ultrasound. This patient has cut their flexor tendons, and we have a really limited window of time to get this fixed, roughly 7 to 10 days. And so hopefully the patient will show up in time for us to get this done. Second myth, I can move it, so it must not be broken. Another thing that's just not true. Even though bones are broken, the muscles still work, and so you can wiggle it even though you may have a significant fracture. The only way to know is to get an x-ray. I'll have friends come to the house and ask me to look, but I tell them, look, unless without an x-ray, we just don't know. Third myth, the numbness will get better with time. And we see this far too often. The photograph in this slide shows a couple of fingers with deep lacerations to the palm side, but even more devastating, a laceration to the palm side of the wrist where one of the major nerves is cut. And I've had folks show up at 3 weeks, 6 weeks, 2 months, and there are things we can do, but really to see this patient early is the key. There's a very big difference between slight tingling and a complete numbness, a complete inability to feel distal to or beyond the level of the laceration. So if there's any question, let us take a look. So carpal tunnel syndrome is an interesting diagnosis. Years ago, I don't know if it was talked about on TV or what happened, but a lot of people have heard the diagnosis. A lot of referring physicians will send us patients that have a hand problem, and it'll say carpal tunnel, but there may be a host of a dozen different diagnoses that may have, but it's enough to get them to the door. They need to be there, letting us look at them. But there's a lot of misinformation. A lot of people feel that surgery is just temporary or recurrence is common, and that's not true. I had a patient recently that I told had pretty bad arthritis in her thumb. And she's like, oh, thanks, doctor. I was so worried I had carpal tunnel. But carpal tunnel is very treatable. So just to talk about what it is pressure on the nerve called the median nerve at the wrist. It's a very common disorder, somewhere between 1 and 10% of the general population. Numbness within the thumb, the index finger, the middle finger, and half of the ring finger. Early symptoms, common to have nighttime awakening. And then as things advance over time, daytime numbness becomes more common, and then that numbness is slow to resolve. In a severe stage, wasting of the muscles at the base of the thumb can be seen, and that's consistent with a more severe and long-standing condition. What carpal tunnel is not. It's not pain in the shoulder. It's not pain in the neck or upper arm radiating to the hand. A lot of times that may indicate a nerve problem of a different nature, such as a pinched nerve in the neck. Focal tenderness to touch over the back of the wrist or sides of the wrist is usually not carpal tunnel, but there are other diagnoses that can explain. As far as how we make the diagnosis, clinical exam, classic symptoms, classic findings on exam are usually very helpful to make that diagnosis. And then we learned a lot from a positive response to treatment. Nighttime splinting can help. An oral anti-inflammatory medicine can help. And probably the most potent thing to do short of an operation is an injection of cortisone within the carpal tunnel. Before surgery, we'll typically confirm the diagnosis with a nerve test, often called an electrodiagnostic test or EMG. And people ask, why did I get this? And this kind of goes back to that information that was spread a few decades ago where everybody thought that you had to type on a keyboard to get carpal tunnel. And it's just not true. I mean, we see various patients that have various activities either at work or at home that may play a role. One of the largest studies in the UK, the largest subset of patients in that study were housewives. We see farmers, we see professional golfers, we see all type of just basically humans that get carpal tunnel. The bottom line, or the cause, is an increase of pressure on the nerve within the carpal tunnel. If you look at the image on the top right of the slide I'm looking at here, basically the bones of the wrist make kind of a trough shape, and there are 9 tendons that go through that space, 2 to each finger, 1 to the thumb, and then the nerve. And so you get a little bit of swelling of each of 9 tendons, and that ends up taking room away from the nerve. As far as treatment, I think I mentioned a minute ago, non-operative, one of the first things to do is to wear a splint at night. The reasoning is that carpal tunnel space, because the bones have motion, and they've done MRI studies and shown that if the wrist between being completely straight and bent, that space decreases by about 25%. And so if you ask yourself, how do I be mean to the nerve, go to bed at night and sleep with your wrist flexed or extended, and it puts more pressure on the nerve. And then doing something to try to treat the inflammation that may exist inside the carpal tunnel that I just mentioned, and that could be an oral anti-inflammatory medication, something like Motrin or Aleve, a Medrol dose pack, and again a steroid injection. Surgery is a very targeted mission where we go to release the ligament that makes up the roof of that bony tunnel. And that can be done through an open technique where the incision's made within the palm, or it can be done endoscopically. And I've got a few more slides here to demonstrate some of that. I tell patients in the office that the ligament itself is about the size of a postage stamp. And our goal with surgery is to basically release that stamp from one end to the other. And so the blue star that you see in the middle image would be equal to what we're seeing, the image on the right, which is the endoscopic view with the camera inside the carpal tunnel, where the transverse ligament has been partially released at that point. A few more images from inside the wrist taken with the endoscope. Top left, you see the transverse fibers of the ligament. If you look at the far end of the image, that's where the blade would raise. I've circled that blue circle. The bottom left image shows the blade elevated, and that's how we achieve the release of the ligament. You can see on the right where I'm holding that handheld device, I'm pulling the trigger, and you can see that tiny little blade is elevated. And in that image, we've already closed the wound. You can kind of see the size of the wound there. I think we've got a live. Well, before we get to that, I just some of the same images here. And normally we don't go looking for the nerve, but for educational purposes, just to show you, if we tilt the device slightly, then the median nerve will come into view. But typically, when we're doing this procedure, the sheath is held tightly against the ligament. It keeps the nerve outside of harm's way. And when we raise the blade, we can't see the nerve, therefore we can't hurt the nerve. So here, I think we've got just a short clip showing driving down to the end of the carpal tunnel, the transverse ligament. I'm pushing on the fat pad in the middle of the palm. I can see that. There's where we had the nerve pop into our field. We asked it to go away. And then once we can confirm that we have good vision at the end of the ligament, I tend to pull back slightly, so I know I'm not too far. We raise the blade. We'll partially release. We'll release about the last 30%. I'll retract and then reinsert. And then there are some fibers at the very end that stand at attention, so we know where the end of the ligament is clearly. And I'll retract and then reinsert and just prove that. You can see the two sides starting to retract. I think that video just flipped back to the beginning, so that's it. So as far as results, endoscopically, we have excellent visibility. The way I described it, we release up to the very end of the ligament, and then we allow those last few fibers to stand at attention. We're able to release the very end and know really with excellent confidence that we've gotten a complete release. I think I mentioned earlier that there's just some information or some thought in the community that recurrent carpal tunnel is common, and it's just not true. I've done several thousand releases in my career. I've done this particular technique my entire career, and we've had very few recurrences, and most of them have been a decade later. But even then, it's just not common. Patients have very minimal pain. They'll take 1 or 2 pain pills and often say, "Gosh, I took it, but I'm not sure I really needed it." And then return to work really depends upon the patient's employment, what their activities are. Someone who's self-employed and really doesn't have to do a lot of heavy labor and can pace themselves can go back to work after the first week or two. Someone that has light to intermediate level work, often at 3 weeks, and then the person that puts the luggage on the airplanes at Delta, something of that nature, may take 6 to 8 weeks to get back to that. Cubital tunnel syndrome is pressure on the second major nerve that heads into the hand, the ulnar nerve. In the high 90s, the problem is at the elbow, not at the hand or wrist. It's a very common treatable disorder, felt to also be present somewhere between 1 and 10% of the general population. I don't think it's nearly as common as carpal tunnel. The numbness and tingling involves the ring and the small finger, typically noted as nighttime awakening. And as with carpal tunnel, in a more advanced condition, daytime numbness is slow to resolve. With severe late stage problems with the ulnar nerve, you get wasting or atrophy of the small muscles of the hand. So the small muscles between each of the bones, actually this muscle between the thumb and index fingers. So someone will have a kind of a flat palm appearance with that. This just graphically shows the nerve course and the couple of fingers that are involved. They'll often have a physical finding where if you just lightly tap on the nerve more than normal, they have a very excitable nerve, and that'll recreate symptoms down into the fingers. Nerve testing is very helpful in confirming that diagnosis. So people will ask, why did I get this? And it's hard to always know for sure. Someone may take a hard blow to the inside of the elbow. They may have prolonged pressure on the nerve, either in their sleep, common at night, or may have a job or have a hobby where there's repetitive activity requiring frequent elbow hyperflexion. But in general, the nerve is happier when the elbow is straight, not so happy when the elbow is hyperflexed. So spending a long time on the cell phone, you'll often notice the fingers start to go numb. And that can happen to anybody. But if you get this condition and it seems to clear slowly or just stay with you, then there are things that we need to consider. As far as those things to consider, nighttime extension splinting. What I show on the graphic here is something that can be purchased. What we tell people honestly to do most commonly is to use a pillow and a soft pillow, try to fold it over to make kind of a tube out of that. Use some safety pins or a couple ribbons to make a soft splint that you can wear at night. It may not prevent all motion, but just in general promotes a more extended posture of the elbow. Sometimes we might put somebody on activity modifications, just trying to minimize repetitive elbow flexion. Avoiding pressure over the medial elbow. Some people that drive trucks for a living, for instance, just describe how they'll rest the arm constantly in a certain way, and that may be a problem. As with carpal tunnel, anti-inflammatory medicine can help. An oral anti-inflammatory medicine or Medrol dose pack. We are not quick to inject cortisone around the elbow because the path where the nerve passes is very tight, and so you're likely to irritate the nerve with that needle doing that. So I don't do that. From a surgery standpoint, when I did my fellowship, decompressing the nerve and moving it in front of the bony bump, called an anterior transposition, was really the standard of care. At that time in Europe, decompressing it right where it lives but not moving it was probably more the standard of care. We thought they were lazy. As things have passed over time, it's really become more common to do the in situ decompression in the United States, just thinking that it's less surgical dissection for the nerve, and that's commonly what I do. If we've decompressed the nerve, we've accomplished that. We'll move the elbow through a range of motion. We'll just watch it. If that nerve does not try to flip across or move across the bony bump, the epicondyle, then we'll stop. If it does do that, then we will transpose it. That's sort of the common sense way we'll handle it. So one of my favorite slides here, in the office, there are lots of days where I feel like running up and down the hallway that I'm the Orkin man. I feel like I need to have a backpack of cortisone because it just seems like injecting people is what we do, but it works. And I think this brings up a couple things that I've had patients ask me, and it kind of ties back to what is the actual cause of a condition or cause of pain. And so you have mechanical pain in orthopedics, and that's the fractures we treat. It's the arthritis, it's joint instability, it's things where there's a mechanical cause of pain. But then there are inflammatory conditions, tendonitis, very early stage arthritis, or just an inflamed joint that we call synovitis. Those are the kind of things that you can almost think of as fire, and with an injection, we're putting water on it. We're putting that fire out. So when people say, I thought an injection was just temporary, that is a true statement when you're talking about arthritis. It is not true for inflammatory conditions, where an injection can often run a 60 to 70% chance of curing that problem with one shot. So in those particular conditions where we may be talking about injecting, we always want to consider other options as well. temporary rest or activity modifications, icing after activity, elevation, splinting, anti-inflammatory medications, a Medrol dose pack. Sometimes if a patient has multiple sites of inflammation, it makes more sense to use a Medrol dose pack than to come at them with multiple needles. I don't usually promote that, and they don't usually want that. But in a lot of cases, an injection is the fastest way and the most predictable winner, just like this sprinter we all know. Surgery is considered for recurrence after 1 or 2 injections, and usually we leave that up to the patient's choice. So for a few conditions where injections are commonly used, where I've got the backpack on in clinic, trigger finger, de Quervain's tendonitis, something called intersection syndrome, several of the wrist flexors or extensors. And I put a comment here about tennis elbow. I do inject tennis elbow, but I see it overdone. I've had patients referred to me essentially for surgery, and they've had numerous injections, but never been told about the importance of stretching. And so that's really what I preach. What the literature is showing is just not that common that we have to operate on tennis elbow. So we really get people doing a stretch, just elbow straight, wrist down. A lot of times it hurts to get started, but that's really the key to the cure. If we inject somebody and they don't stretch, what happens? They feel great for 2 weeks and comes right back. For trigger finger, for instance, we can do an injection and they can completely ignore the condition and it gets better. Triggering is basically swelling of the tendon where it enters the finger. Over time, that tendon will actually swell and get some nodular change like the image shows there. They'll have localized pain, stiffness, swelling of the finger, and a painful click or even locking. Some patients will wake up and they literally have to help their finger straighten. Early morning symptoms are commonly worse. That's when people will notice the finger to be locked. De Quervain's tenosynovitis, one of the many conditions that we treat named after a French person. They ran around naming a lot of different conditions after themselves, so we've got the name. This is similar to trigger finger, but it's the extensor tendons that are headed to the thumb. They go through a compartment over the thumb side of the wrist, and you get swelling and some nodular change and just localized pain. Patients will come in concerned that they have a fracture, that they have a pretty serious condition, and they'll ask me why I'm smiling, and the reason is because typically one shot and we can cure this. Intersection syndrome is nowhere near as common. There are 2 sets of tendons that cross over the back of the wrist in this general area. Similarly, causes pain, causes swelling. What's really unique about it is, in some cases, if it gets bad, it'll literally make a noise. It'll squeak. So it's one of the few conditions that I know of where it literally makes a noise. Rarely surgical. If we inject it, that'll usually take care of it. Ganglion cysts. Most people have probably heard that word. A ganglion cyst can essentially happen in any joint in the human body. Any place where 2 bones come together and make a joint, you can have a natural weakening or just a spot where that joint fluid will push up and slowly form a small mass that's filled with joint fluid. That joint fluid loses its water content over time and ends up being a very thick fluid that's inside that cyst. Probably most common is the mass on the top of the wrist, the back side of the wrist. We're pretty quick to offer aspiration for that. I wish that came with a higher cure rate, but it's roughly 50-50. and it's something easy enough to do in the office at the time of the first evaluation. And if we're lucky enough to resolve it permanently with that, great. If it comes back, I tell patients it's really has to do with the timing. If somebody comes back a year later, then more than likely they're going to say, "Hey, doc, do that again." If it comes back earlier, then we may choose to surgically to take it out. And even with surgery, we know we take the complete cyst out. We take it out by the stalk that you can see the image on the lower right there. There are some recurrences. The book answer on that is about a 5% recurrence rate. And then there's the cyst that happens on the finger. It's basically a ganglion cyst, just called by a different name, a mucoid cyst, and the same treatment options for that. A little bit on wrist fractures. When we say wrist, technically wrist is the joint, but the bone just in front of the wrist is the radius. We call it the distal radius, or it's the end of the radius. One of the most common orthopedic injuries, 18% of all fractures in adults. Women, 2.5 times more common to fracture than men, although it happens in both. There's a high incidence in females over 50 years of age. There's also a bimodal presentation, meaning two patient classes. One, younger patients where the fractures are usually due to high energy, whether it's falling from a skateboard, falling out of a tree, car wreck, whatever. And then older patients where it's just a simple fall. There's some surgical treatment, and I've seen all of this. I don't feel old, but I've seen a lot. Pinning of distal radius fractures was really pretty common when I first went into practice. And it worked, but it was nowhere near as good as what we have available to us today. When we pinned a fracture, it was not rigid fixation. In other words, we still had to depend upon the cast quite a bit to maintain the position so that it healed properly. And in those patients, even though we took them to surgery, we put pins, we still had to put a cast above the elbow. And those are days that I'm glad are gone, to be honest. Another thing of historical significance, I say that, I mean, there may be a rare need, perhaps a gunshot wound or something really not common, but what's called external fixation. This was very popular, and I think it was something that general orthopedic surgeons felt pretty comfortable putting this on, no matter how bad the fracture was. The problem was if you over tensioned, you put too much tension across the fracture, you got really stiff fingers. Sometimes you got a pain syndrome called reflex sympathetic dystrophy, where the pin in the forearm goes. There's a nerve that lives there. I saw nerve injuries there. So I'm glad that this is not commonly used. So what really came along, and it ties a lot to innovation in orthopedics in general, because when I first went into practice, if you put a plate on a bone, when you put the screw through the plate, basically it would dangle. So just think of going to Home Depot and buying a little metal plate. You drop a screw in there and it dangles. Plates that we have today, when that screw engages the plate, it literally locks to the plate. It's rigid, and that technology was first developed for plates for the wrist, for the distal radius, and that technology has really spread all across all of the fixation systems that we use in orthopedics. Huge advancement for bone fixation. So for the wrist, what it allows us to do is early range of motion and removable splinting. Some physicians will start patients moving at a week. Honestly, my preference is that patients aren't quite ready for that. And so what we'll do when they come back for their first post-op visit is we'll put them in a cast for 2 more weeks, a week or 2 more weeks to get to that roughly 3-week mark. At that point, the swelling's down, pain's down, and they're really ready to start their therapy. So patients, by plating these fractures, they're much easier to manage. It's much easier for their family to pitch in and help. And we have a high rate of good to excellent results when you look at range of motion, strength, and return to normal activities. Also around the wrist, fracture of a bone called the scaphoid. It's a small kidney bean shaped bone just beyond where the wrist moves. And this is a problematic fracture for a couple reasons. One, the fracture is commonly missed. 2, it doesn't heal predictably in all cases. 15% of all wrist injuries are fractures of the scaphoid. Unlike distal radius fractures, it's more common in males, 2 to 1. There's a younger peak age in the 3rd decade, but we certainly see patients on both sides of that. Clinical suspicion is really key here, because if a patient comes in and they describe a fall, hyperextension of the wrist, almost I say pone, just a swelling over the back and the thumb side of the wrist that comes up fairly quickly. Pain in that, what we call anatomical snuff box. That's a fracture till proven otherwise. Initial x-rays can often not show the fracture. And so at the end of every high school football season, in January or February, I'll get 3 or 4 high school football kids who had an injury, and it hurt a lot at first. I'm not saying the coach said, "Hey, throw some dirt on it," but bottom line is they didn't get in for evaluation or treatment, and they show up with a bone that has a true, what we call non-union. And at that point, we basically have to do surgery to try to get it to heal, because if a person goes through life with that bone unhealed, they will get a very predictable pattern of arthritis. It takes 10 to 12 years to develop, but it happens 100% of the time. So one of the reasons, or the primary reason that bone has issues is its blood supply. It's a very unique blood supply. The scaphoid's covered in cartilage by about 80%. So there's just about a 20% area where any soft tissue comes to attach to it. And so that's how the blood supply gets to it. The bone at the upper end, the end closer to the elbow, is the end that's really threatened with regard to its blood supply. So treatment, if we identify or suspect a fracture and it's completely non-displaced, we'll use a cast. There used to be literature that said that the cast needed to be above the elbow. Fortunately, somebody proved that wrong. So a cast below the elbow is adequate. And we basically just have to treat until we're convinced that it's healed. And in some cases, if there's any question, we'll get a CT scan to confirm it. If there's displacement, and we're talking just a millimeter or 2, which is not much. In fact, the image shown here just isn't going to heal on a cast. And it's been proven that displacement more than 1 to 2 millimeters is a much higher chance of non-union. So we'll repair that with a screw. If somebody presents late and there's bone that has been resorbed or melted away along the fracture site, we'll put bone graft in addition to the screw. And there's techniques where we can put the bone graft down the screw track once we've drilled for the screw, but before we put the screw, we can pack bone graft down that track to improve the biology before we improve the mechanics with the screw. Next, arthritis. of the fingers. And this is a bit disappointing for me because I really wish we had better options. Um, Osteoarthritis, often we'll call it OA. If you ask a hand surgeon, where does that happen? Basically the base of the thumb, and then the last joint, the DIP joint, and then the middle joint called the PIP joint. Those are the common joints to be involved. When we're talking about the middle joint or the PIP joint, oral anti-inflammatory medicines. There's a topical anti-inflammatory medication that we'll use. We will use joint injection. I won't say sparingly, but we really want there to be an active flare. That's when you're going to get the best effect with a shot. And if somebody has some instability, there's some splints that are made that are not terribly bulky. There's one company called the Silver Ring Company. They've made splints that almost look kind of like jewelry, so that they're tolerated. But from a surgery standpoint, the most dependable procedure is a fusion or an arthrodesis, where that joint doesn't bend. We pick a level of flexion roughly 35 to 45 degrees, and that's largely, I mean, rarely recommended by me. There was a time when movable implants or an arthroplasty, like you would see in a hip or knee, was done. These have largely fallen out of favor due to what a lot of people would say less than optimal, or I'd say poor results. This slide just shows what that looks like. Probably 15 years ago, there were some people that felt that pyrocarbon, which is the type of material here that was going to be really the savior, and was highly touted. The problem is over time, these implants have just been shown to migrate through the bone. I'm not sure exactly how that happens, but bone is always remodeling, remaking itself, and for some reason it's basically kind of kicking this implant out. And so I never did many of these. I'm glad I don't have a lot of these out in my practice, because they just haven't done well. The last joint, the DIP joint, is more commonly operated. Really not a movable implant here either. An arthrodesis or a fusion is what we will do. And at that joint, extremely well tolerated, especially if the patient presents and they have instability or just a floppy joint. That patient will do very well to have that joint stabilized with a fusion. Maybe getting close to the last topic here. So thumb arthritis, we call it the basal joint or the CMC joint, which stands for carpal, metacarpal. The image there shows the red bone, indicating that it's not happy. It's called the trapezium. This arthritis is seen in 25% of men, 40% of women over the age of 75. So it's a very common condition. The majority of people that have this never have symptoms that warrant surgery. But if we do, we treat someone and non-operatively for a period of time, and we're just not getting them where they can do what they want to do, where they can sleep comfortably at night, then we will offer surgery. Patients who have increased joint laxity seem to be the ones that show this condition more commonly. And I think that's where what makes it more common in females. Some of the same stuff as far as non-operative options with regard to topical pills, joint injection. We have a brace, or a brace can be very helpful to help immobilize that joint. A lot of times we'll recommend the brace wear at night. For some reason, wearing it at night, not sleeping on it in an awkward position, can make a real difference for the day. There is a therapist that came up with a set of stretches and exercises for arthritis. In the beginning, I really wasn't sure what to think of that, to be honest, but I've been turned into a believer. And so there are some stretching exercises that can be done that can help a patient that has arthritis at the base of the thumb. So what we do surgically, any procedure involves either partial or complete excision of the trapezium. And on the right, just shows a few of the different things that are considered. A stemmed implant, a lot like you would see done at the hip. There's something called an LRTI, which stands for ligament reconstruction with tendon interposition. And then at the bottom, mini tightrope suspension plasty. And so as far as the stemmed implant, has somewhat fallen out of favor. And I never did many of these. I think there are issues with instability, issues with the implant subsiding, and there's always that risk that it fails in the future. And so I prefer something that is going to hold up long term, and we're really not going to have to consider any future surgical considerations. And the couple things that are options there. What I learned in my fellowship was the LRTI. To be honest, always hated that operation. Hour and a half. You're harvesting a tendon from the forearm. You've got several incisions in the forearm. Longer surgical time, and I was really searching for something different when I came out of my fellowship. And so what we landed on 9 or 10 years ago was the mini tightrope procedure. And with that, we excised the trapezium. We have an implant that's basically a flexible, strong suture held with a think of it as a washer on both ends, and it controls the position. It prevents the thumb from subsiding. There was an operation that we did before the mini tightrope became available where we put 2 pins, and the president of the Hand Society about 15 years ago wrote a paper with 20-year follow-up where he did that procedure and took the pins out at 5 weeks. At 5 weeks, there was nothing left in the thumb, and the thumb was stable. So that was a precursor to the mini tightrope. So what we know with that is that device we could take out at any point past 5 weeks, and it's not needed, it's not necessary, but we don't have to take it out because it's flexible. So it gives us a good long-term option with a shorter surgical time, shorter need for casting, which we put patients in a removable splint at 3 weeks. And a lot of people may recall the National Football saga with Alabama's quarterback having this ankle injury, and how the Alabama team doctors invented this new technique to get him back on the field. And just want to remind folks that we've been doing that for 9+ years. Go Rebels. And that's all I got.
All right, thank you so much, Dr. Cole. And thank you everyone for hanging in there and watching this very informative presentation. We do have some questions, so at the I will begin asking them. Just a reminder, if you do have any questions while we're talking, feel free to type those into the chat box, and we will do our best to have them answered for you. The first question I have is, and we may have already covered this, by the way, what could be the problem with a ring finger that does not move with the other fingers or makes a popping sound?
I didn't completely hear that question.
I apologize. A ring finger that does not move with the other fingers, that makes a popping sound or feeling when trying to make a fist.
Okay. Yeah. I mean, I think that sounds like a trigger finger. Um, if there's pain in the palm, a trigger finger will often make it harder to move that finger down. The popping makes sense. I mean, I think that's probably a trigger finger, and a problem that's easily treated with an injection.
Thank you very much. The next question is someone has a thumb on their hand that is bent at the joint when they wake up and it's aching. And then it pops and the movement isn't smooth, but it returns to normal. And then later starts popping and aching again. What are some things that might be, and what do you suggest that the person come in and be seen?
And you said thumb, right?
Correct, thumb.
All right. I think it's a trigger thumb.
Okay.
Yeah. And I'll tell you, it's if I'm in the office all day long, let's just say on my Monday, I may see 6 or 8 people that have a trigger digit, either a finger or a thumb. It's very common, very, very common. And people are usually relieved because they think the worst. They think, "Oh my God, what is this?" But it's a good problem. We can make it better.
Oh, fantastic. Another question here, and I don't think we covered this in the presentation. Do you treat Dupuytren's contracture?
I do. So Dupuytren's is another condition named after a French person. We all have bands of tissue in our palm called palmar fascia. Palmar fascia is what gives the firmness to our palm. So when you put something important in your palm or you're pulling, the skin needs to be needs to be firm. And so it's that fascia that in some patients will start to get a little nodular change, or even get a little, it almost looks like scar. In some cases starts to draw the finger down. It's felt to be associated with people of Northern European ancestry, but to be honest, I've seen it in all walks of life and folks that live here in Memphis. So I do treat that. There are 3, I guess the take-home points is what we call the tabletop test, meaning if somebody has a nodule in the palm or something that can be felt as a bit of a cord, but if they can lay the hand flat, we call it the tabletop test. When we lay it flat, then the best thing to do is to do nothing, just watch it. If it starts to draw a finger down where it won't go straight, that's when you consider doing something. And there are options. If it's just drawing the first joint down, there are 3 options. You can use something called needle aponeurotomy, or use a needle to put numbing medicine and fatigue that band enough to where you get it to break. It's an office procedure. I don't do it. I send those patients to Dr. Williams, one of my partners. There's also something that's being advertised that is a chemical that you inject, and it helps to melt that band, and then it requires an office procedure to stretch the band and get it to rupture. And then the third thing is to do an outpatient surgery and make an incision to take the band, take the cord out. And more commonly, where I get involved, because I don't do those other 2 office procedures, is if the middle joint, the PIP joint, if that starts to bend down, the injectable and the needle procedure aren't as effective or as safe. And so those require an open procedure. And so I will do that. When Dr. Borland was here and with us, he had a huge Dupuytren's practice. And so all the patients, we funneled Dupuytren's patients to Dr. Borland every ever since he retired and then passed, we've had to reinvent how we're managing Dupuytren's, and I take on the more difficult open procedures, and I'll refer um, the office-based stuff to Dr. Williams.
Fantastic. Great answer. Thank you so much. Our next question is, if someone has a hand that feels kind of crunchy when they open and close it, no swelling of joints, what could that be, and do you suggest they be seen?
Trigger finger. I think that's a trigger finger.
I sense a trend.
One thing to mention, just one thing that could be confused with the trigger finger is every once in a while the tendon on the top of the middle finger, the long finger, that tendon can slide over into the groove. And it can often be just a minor injury. Somebody will feel a pain and they'll notice that tendon slipping back and forth. So that can be confused with a trigger finger, but I think the patient you're reading, that sounds like that's what that was.
Thank you very much. Next question I've received. If someone has a sharp but fleeting pain, sometimes on the inside of the wrist, running up the arm, and sometimes at the base of the thumb or on the other side, when should that person see a doctor? It's a very specific question.
It lost me a little bit. Tell me again, read that again.
Sure. Sharp but fleeting pain, sometimes on the inside of the wrist, running up the arm, sometimes at the base of the thumb or on the other side. So basically on the inside of the wrist, near the base of the thumb, or the other side, running up the arm.
I'm not gonna get that one. I don't think. I think I don't know if that person had pain and it persisted beyond a couple weeks, 2 or 3 weeks. Maybe if they've tried some Motrin or Aleve, or maybe worn a splint, and it just keeps. If it doesn't resolve, I think that's somebody we should look at, because there's a host of things that we might diagnose there.
Right.
Nothing bad, but I think things that we could make better if we just had a more clear idea where that's coming from.
Thank you. The next question, does diet help with any of these inflammatory conditions?
We are what we eat. I always tell patients, because patients will talk to me about different things they're doing and trying, and I never talk bad about things I don't understand, and I am not an expert when it comes to foods and their effect on inflammation. So there probably is an answer of yes there, but I'm not your guy to really point you in the right direction.
All right, thank you. Next question, if cubital tunnel surgery is deemed necessary, what is the general recovery timeline for that surgery if it's needed at the elbow? And if it's, it's a
Yeah. So, I usually tell patients recovery, it just depends on how you define it. What does that mean? Is it when you get back to lighter activities? Is it when you get back to work? Is it when you can go play sports? So like I mentioned earlier, most commonly we will do an in situ decompression, meaning we make a decision about that big. We release the tissue that it lives on the surface of the nerve. So there's no bands of tissue putting downward pressure on the nerve. And then we leave the nerve where it lives. That particular operation is a faster recovery than when we have to transpose the nerve. And so most people get back to a lot of what they want to be doing by 3 weeks. And it's just symptom dependent. We're not beyond just protecting the wound and making sure that they're not stressing the wound with heavy impact or whatever, they can proceed with activities to pain tolerance after about 3 weeks.
Thank you. And the next question here is, what is the success rate of basal thumb arthritis surgery?
Success rate?
Yes, sir.
High. Yeah, so with what we're doing, the mini tightrope procedure, 9 years ago when we first started, it was more thinking, okay, this is an elderly female, low demand, not out playing rugby, whatever. But really, as time has gone on, we have treated patients males that do heavier labor. And so, just like I described, when we did the procedure where we put 2 pins and took the pins out at 5 weeks, that thumb had developed significant stability. And so we have not had to revise any of the mini tightropes. It's actually a procedure that is used to salvage other failed procedures. Like, for instance, if somebody had an implant and the implant became unstable, we would revise that by taking the implant out and doing the mini tightrope procedure. So we've been very, very happy with the outcomes.
Excellent, thank you. And just a note to everyone, I have one more question here. So if there are no questions after that, we will end. If you have a question, go ahead and get it into us. This last question that I have says, if someone has swelling in their thumb joint and nothing helps the pain, and the joint is bone on bone and injections do not help, could the mini tightrope surgery be a good option?
Yes. I mean, that's really where we would define failure of conservative treatment is no longer is splinting working, the injection's not working. I think that patient would be benefited to consider surgery.
Excellent. Well, I'm going to give it just a second here to see if anybody has any last minute questions. Dr. Cole, we certainly thank you for your time with this webinar, very informative presentation. A reminder to everyone, we will be posting this recorded webinar on our website under our news section at orthosouth.org. We will also be sharing it via our social media channels. So make sure that you go and like and follow our Facebook page or our Instagram if you have not already. And look out for future webinars coming your way in the future. If you have any questions that do not get answered here tonight, feel free to email me at mkandel@orthosouth.org. That's mkandel@orthosouth.org. And I'll get your question to Dr. Cole and we will get an answer for you. Thank you so much for your time tonight, everyone. Have a great evening, and thank you, Dr. Cole.
Thank you.